Emma Runswick is a junior doctor in psychiatry in the northwest of England. She's also the deputy chair of BNA Council, a union which is still engaged in multiple pay disputes in England, Wales and Northern Ireland, so you're very busy as a union.
Very much so. Yeah, it's interesting. I come to these meetings sometimes and hear people talk about the strike wave that has happened past tense, and we are still very much in dispute at the moment. We've just called 9 more days of strike action for junior doctors, and we are in the middle of a reballot for consultants and staff doctors. We have ballots open in Wales and soon in Northern Ireland as well. And what's quite interesting about the way that our struggle has developed is that it's almost isolated from the rest of the labour movement for a whole number of structural reasons and political reasons. We are a Frankfurt union, only doctors and medical students, and we're a professional association. And those two parts aren't in conflict for us. I very much see professional as political. Lots of that stuff is public health work, it's about lobbying work, it's international stuff. And we're not in the TUC, don't historically really have links with anybody who turn up to NHS Staff Council, and we don't get very much involved because it's all about change stuff, but all the other staff are on those contracts, separate contracts. So we've got that separation. We've also got some really interesting structural benefits. So because we have to maintain registration, all of our elected members, including myself, still work. All of us. I'm the equivalent of the Assistant General Secretary and I work half-time clinically. Even the equivalent of the General Secretary, Phil Banfield, works 1 day a week as an obstetrician and a fifth of his on calls. So all of us are still in work, all of us are still very connected to what we're doing, who we are fighting for with alongside. We also have term limits. My term limit is 3 years, and then I can stand for another 3 years, and then that's it. And that applies for everybody. You can only have 6 years maximum in the leadership of the organisation. So those kind of structural differences mean that rapid change in the BMA is very possible, and that building up good campaigns has enabled us to take over quite substantial amounts of our trade union quite quickly. It's worth saying that we are keen to work with others. So this iteration of the BMA is keen to work with others, and we have taken strike days with other groups, including mostly dentists and radiographers, who, not on those strike days, but on others. And we had spoken extensively to NEU and RCN before their disputes ended. But what we are not willing to do is work in unity at the expense of good policy and strategy. So where unions have come to us and said, oh well, we want to have X, Y, Z days of action, and it's pathetic, the answer is no. The answer has been no. So when we were talking about coordination, we weren't just talking about coordination same days of action, we were talking about let's coordinate, a group of doctors on Monday, nurses on Tuesday, a group of doctors on Wednesday, physios on Thursday, social workers on Friday, cleaners on Saturday, and you can take out extensive periods of time from elective work through coordination that isn't simultaneous. In fact, we originally attempted the kind of campaign of pay restoration came from attempts from leftist, socialist organisers in the BMA to join NHS Pay 15, the NHS Workers Say No campaign. And as we were beginning to make differences, change in our union on that issue, ordinary members, people who were not active, responded to that by saying, well, why are you asking for less than we've lost? And we say, look, we've lost 26% of our pay since 2008. So we're joining this NHS Pay 15 campaign for 15% pay rise. My colleague said to me, well, why are you only asking for 15% if you've lost more than a quarter of your pay? Completely legitimate and reasonable question. And that shifted us very rapidly to the pay restoration demand. And we haven't been prepared to shift and tone that down to fit with, for example, the RCN strategy of halving your demand before you even enter negotiations. We get the criticism that people make about, strikes are long haul and the difficulties that creates. But I'm very much of the opinion that even if your strike isn't a marathon, organising is a marathon, and we were not ready to take strike action in the summer of 2022 when I was elected. When I was elected, we had about 160,000 members. We now have more than 196,000. We've recruited 36,000 people into the BMA. But that density, if you look at the number of people who are on the GMC register, was well below 50%, close to 40%. We're now reaching 50% density. Amongst junior doctors, our density is almost 90%. So that has been a massive shift, an organising campaign on the basis of important demand, a demand that invested in, that people understand, that has basic fairness at its heart, that highlights the absolute decimation of the health service that we've faced since 2008. And we were doing that analysis of our position honestly, not in reaction to the government positions, in response to the attacks. And again, it's in quite dramatic contrast to some of the other NHS unions that went, called strike action and then failed to get their balance across the line. And of course, almost entirely, those disputes have burnt out because they didn't do the organising work that was required. We've also got difficulties working with other unions because we are unusual. Junior doctors are rotational staff. We are not permanent in any workplace, and that is not handled well by most organisation strategies that are currently in use, particularly the servicing models. If you literally have to move jobs every 6 months, and there are some doctors who move every 4 months, and I always put in my bio North West England, I could be anywhere, right, in that area, in that big area, and that requires us to develop strategies that are much more similar to the strategies that were in use with itinerant workers in this kind of period than the strategies that are in use by most public sector unions. So it's worth talking about the outcomes from that. What's the outcomes from that? Well, we have the best, we're not out of dispute yet, and even in that circumstance of not being done, we have the best pay rises in the public sector. In Scotland, 17.5%, and 3 years of at least inflationary pay awards and contract reform. In England, between 6 and 10%, depending on your grade of doctor. We've just been offered another 5% plus pay review body reform for consultants and 3% for juniors, which we've straight back rejected. And I am absolutely confident that we can win more than that. Absolutely confident we can win more than that because of the organising work that we have done. It's interesting when you look at that to think, well, is this massive group of workers who have joined the BMA and got involved in struggle and been on strike and taken to picket lines and done that organising work interested in the rest of the labour movement? And I've got to be honest, the answer is no. And I should be honest about why. We recently talked to our national conference a motion to join the TUC, and the arguments against came from some of the most active members, some of the people who have got very heavily involved in the pay dispute, but do not have a left-wing background in the way that I have a left-wing background. And the arguments that they made were, well, this is a really high cost for very limited benefit. They only look at very few unions as being worth working with. The RMT maybe, but other unions, well, we're doing quite well on our own, and many of them are sellouts. Why would we want to be involved with them, right? So if we are going to be able to broaden out from just doctors in the BMA to a wider trade unionism across the NHS and across the whole labour force, as people like me and other people in the BMA are trying to do, we need to be able to bring in political education for our members, and we need to be able to generalise the organising strategies that we've used with our members to other members who are now quite keen to join us because we're doing well, having always thought that we've worked with before. Hopefully, by doing events like this, and we're doing similar in our own union, though not with use and support for the reasons I've just described, we will be able to make those things better. We will be able to build up hospital-based and regional-based, and as I said, we're rotational staff, so we can't just stick as out and go, oh, you're just one workplace, it doesn't work for us. And we will be able to build up that power, and we will be able to win not just doctors, and I'm absolutely certain we'll win for doctors, but also for other health workers, for patients, and for all workers.